a lot of times if you look up atherectomy, if you look up a lot of papers, they'll say one of the indications is if you're trying to not stent. Is that something now, Srini, that you are you trying to do atherectomy to avoid stenting, or is it actually kind of like Omar said that you get a better result post stenting? What would you?
I mean, I think that's where part of the controversy is, right? I mean, is atherectomy really indicated, right? There are many that believe that there's no good data to give you an absolute indication that says you have to do atherectomy. Obviously, that's where you have kind of two camps. And then there are those that believe that, yeah, we should do atherectomy. I think what Omar says is spot on. I think IVUS helps direct kind of atherectomy choice, or whether you're going to do it or not. In most cases, in my opinion, I guess that's my opinion, obviously. And I think, IVUS helping in terms of plaque composition. Do you have soft plaque, calcified plaque? Is it mild, moderate, severe? Do you have thrombus? Those are all the kind of things that will help kind of direct you towards what type of atherectomy you're going to use, I think, in many cases. Regarding the no stent zone, obviously most people classically think of the popliteal artery, especially behind the knee joint, below the knee, so the P2, P3 segments. And in general, the popliteal artery as a whole as a no stent zone. In other words, with all the forces from twisting, bending, and so forth, and rotation, you kind of want to avoid stenting. And so some people make the argument that, look, that's where vessel prep is the most important. And we really should be doing really good optimized atherectomy in those areas. Again, you can argue about what type of atherectomy, but they'll say we should do some type of atherectomy for good vessel prep so that we don't have to stent. And I think if you look at all the data on atherectomy, one thing is clear is you definitely have a lower bailout stent rate compared to when you don't do it. Whether it helps you for primary patency, TLR, amputation-free survival, limb salvage, and, future outcomes, that really hasn't been borne out, I think, definitively at this point.
Got it. And I mean, you've mentioned this a couple of times, and I think maybe I was going to save it for later, but like, where does the data lay for atherectomy? I mean, that's probably the first question people ask when they try to debate atherectomy. What data is out there to support it or to not support it?
Yeah, I mean, I think part of the problem is that, with atherectomy, you don't have any really good randomized control trials, right? You don't have good RCTs. You have retrospective analyses, prospective studies. You've got some registries, as in the Liberty 360, which shows you, in a lot of these studies which show you that there's in terms of feasibility and safety, they're quite good. But in terms of all the other things, does it really make a difference in terms of outcomes? I think that's the one thing where both camps are always having a debate and a discussion. I think where we do have RCTs is in ISR, right? I mean, technically with ISR, laser atherectomy with Excite, has been shown. But again, the numbers weren't huge. So, again, that's where the debate comes into. So I think one thing we need is, and we don't have head-to-head comparisons between a lot of these devices. Is orbital better than rotational, better than laser, better than directional? We don't know. So I think the data is where we really need to kind of improve on at this point.